Hi everyone, I want to talk about keloids. You've heard about keloids? Okay, let's go. Keloids are fibrous growths beyond the injured area with excessive collagen production. In other words, when someone is having keloids, it's going to swell off more than the region where the injury had occurred. And it's going to be thick, firm, solid that you can even hold. But that is different, when you are handling hypertrophic scar. Slightly similar, but keloids may not regress over time, while hypertrophic scars are confined to the injured boundaries and will regress with time. Epidemiology. Keloid is very common in blacks and Hispanics. It's up to about 10% of blacks and Hispanics. Male to female ratio is 1:1. In other words, it's equally spread amongst male and females. It is more in younger age group, and familial tendency is very high. It is autosomal dominant inheritance. Okay, the pathway is not so clear, but we know that involves alteration of the organized process of wound healing. Why that? Because that's not the normal way for wound to heal. And it is influenced by genetic factors. I've just talked about being blacks or Hispanics, and of course, autosomal dominant inheritance. The Fibroblasts proliferation and collagen synthesis are appreciably increased. We have what is called minor keloid. And ask me more. How do you mean by minor keloid? Okay, that will be focally reached. Pruritic, beyond bone borders. And of course, there will be genetic component. It is typically at earlobes, the chest, shoulders, upper back, head, and neck. May develop 1 year after a burn, so might not develop immediately. Now, somebody had burns or whatever this year, and it's going to take more than a year before you start seeing keloid there. There is no spontaneous regression, unlike hypertrophic scar. The occurrence after surgical excision is very high. So you take the child to dermatologist or plastic surgeon, they cut it off, it's going to come back. Major keloid, on the other hand, is large and painful. Pruritic, that means there'll be itching, and they go beyond borders. Even from minor trauma, an individual could start growing keloids. There will be no spontaneous regression here. Continues to grow in size over years. Now, let's get back to the origin, the genetic relationship of keloids and the affected individuals. Keloid is associated with two genetic syndromes. Imagine that. So, keloid is not just what we can overlook when it comes to genetic relationship. So, okay, there are two syndromes. Robinstein-Tebbe syndrome, and that will have big toes, broad thumbs, some special or peculiar facies, mental retardation, there will be high malignancies, and the individual will have multiple keloids on chest and shoulders. Do you know the problem here? It doesn't have to be secondary to burns or ears piercing or any bite or surgery or cut. Could develop spontaneously. Spontaneously. My syndrome is X-linked. With X-linked, there's a different topic entirely for X-linked related conditions, because once you find the definition to be X-linked, then something should flash in the brain that the females involved here will be carriers unless they have homozygous XX for that particular situation. Okay? If not, it's only the male here, the offsprings of the woman that are males, that will be affected. And the affected male will pass the gene to their own daughters, who will be carriers, and then in future we have carrier daughters and affected males, except the XX is homozygous. That is when the female could be affected, but that is not common. So in Goeminne syndrome, there's possibility of torticollis, spontaneous keloids also. What is giving me concern is the fact that in these conditions, as the first condition I described and this one, you don't need to have a cut. You don't need to have piercing. You don't need to have inside bite. You don't need to have burns. It could just develop spontaneously. And particularly in this case, the individual will come down with multiple keloids. And of course, like I've just said, because it is X-linked, we expect the phenotypic manifestation to occur in the male child. And the male child could have what we call chrysochism, which is undescended testes, and of course renal dysplasia. How do we make the diagnosis? It is clinically diagnosed, but it's a pathological examination to rule out other possible differential diagnoses could be made. What are the possible differential diagnoses? The first to come to mind will be hypertrophic scar. An hypertrophic scar will regress with time, and they are limited to the injured area. They don't go beyond the boundaries of the injured area. Nodular scleroderma is another differential diagnosis. It could also be called keloidal scleroderma or keloidal morphia. They are very rare. And when they occur, they are firm, they are non-tender, they are in form of nodules or plaques. They are found at superior portions of the thorax. Dermatofibrosarcoma protuberans. That is very rare. But when it occurs, it's very aggressive and is a form of cutaneous soft tissue sarcoma. How about giant cell fibroblastoma? That's a juvenile form of dermatofibrosarcoma protuberans. Lobomycosis is another differential diagnosis that is formed when there's fungal infection, but they are keloid-like papules or nodules and could be plaques. Treatment. How do we treat? The first thing is to take the picture of the keloid right now so that you'll be able to compare it later on as you continue. Okay? You can use Vancouver scar scale for vascularity, pigmentation, pliability, and the height of the keloid. We're going to find out what is the main concern as far as the affected individual is concerned. Is it the pruritus, is it pain, or cosmetic reasons? Let the patient know that there is no cure, because whatever you do today, you might have to do it years to come because it's likely going to reoccur. And you are likely going to have repeated treatments with multiple modalities that may be required. The target is to decrease pain, to decrease itching, and decrease the size of the keloid and the scar. And of course, let the patient be happy, giving him or her the best cosmetic appearance. Now, treatment we can employ are intralesional corticosteroids in form of triamcinolone acetone. You can also use intralesional fluorouracil. And when I was in medical school with our plastic surgeon, in those days, we used to give intralesional corticosteroid with cyclophosphamide combined. Some would use silicone gel shields. Some would try to apply pressure therapy with pressure garment. Isn't that interesting? They use pressure garment, bandages, or special devices to apply pressure there. Well, they know how to do it, that is not cause ischemia in any form. Cryotherapy intralesional is also welcome. Okay, if you've done the conservative measures and you are not winning, then you embark on surgical measures. Here is mainly 4 things. You're going to have what is called excision, fluorouracil, imiquimod, and radiotherapy. Okay, or cryotherapy as the case may be. But let's go. Excision. You do your excision and you give your steroids after. That's one way you can do it. Or you have excision but before the operation, or during the operation, or after, you give your corticosteroid injection in form of triamcinolone acetone. You can also have excision and then give fluorouracil after, now post-operative. You can have excision and have cryotherapy after the excision. Okay? You can have the excision and have imiquimod after. You can also have excision and have radiotherapy after that. And that is very highly effective. But know it, know the side effects of radiotherapy, and explain in total to the affected individual. You can also have laser therapy. And laser therapy is actually good. You can combine intralesional triamcinolone with either fluorouracil, imiquimod, cyclophosphamide. Like I've said, that was the mode then when I was in medical school with my plastic surgeon. Bleomycin, mitomycin, rapamine, and collagen. Prevention. Of course, prevention is cheaper and better than cure. That is, if it is curable. But as far as keloid is concerned, it is not curable. However, you can do everything to make the cosmetic purpose be achieved. Once there is family history or personal history of keloid, then avoid the following: trauma, that is, if it is possible, but I doubt it, but just try your best. Surgery, it is not necessary, Just don't do surgery for fun, particularly in a country where you're not going to pay for the surgery. Ear piercing, that is easy. You don't have to. There are so many other ways you can beautify yourself with jewelries without necessarily piercing the ears. Removal of benign lesions, treat acne or bites quickly. If undergoing surgery, then keep the wounds moist, decrease tension on the wound, and avoid sun exposure. With that, I've come to the end of presentation of keloid. Now, I've briefly mentioned hypertrophic scar. The main thing, as far as keloid is concerned, is tracing the root to the gene, genetic constitution, and letting the affected individual know that there's no cure. And with that, I'm saying a big thank you for listening to my presentation. Kindly subscribe to my channel so that you can get my presentations immediately they are published. Thank you.